the New Jersey Center for Tourette Syndrome and Associated Disorders, NJCTS. Its directors and employees assume no responsibility for the accuracy, completeness, objectivity, or usefulness of the information presented on our site. We do not endorse any recommendation or opinion made by any member or physician, nor do we advocate any treatment. You are responsible for your own medical decisions. Now, I'm going to turn over the introductions of our speaker to Martha Butterfield, the webinar coordinator of NJCTS. Marty?
Thank you, Kelly, and good evening, everyone. Welcome to tonight's webinar. Before I introduce our presenter, I'd like to call your attention to the slide on your screen about our 5th annual New Jersey Walks for Tourette Syndrome event being held in Mendham, New Jersey on November 15th. Proceeds from the walk will fund our educational outreach programs. If participating in the walk is not possible, I urge you to please log on to our website and make a donation in support of our educational programming. Tonight's webinar is the second in our series on mental health stigma across different ethnicities. Our first presentation on October 8th was by Dr. Andrew Lee, who addressed stigma in the Asian American community. Dr. Lee's webinar is archived on our website. Tonight's presenter is Dr. Christine Adkins-Hutchison, who will speak on mental health stigma in the African American community. Dr. Adkins-Hutchison graduated from Princeton University with a major in psychology and received her clinical Psy.D. from the Graduate School of Applied and Professional Psychology at Rutgers University. She currently serves as the Associate Director of the Office of Counseling and Disability Services at Kean University. There she provides individual and group counseling to students and offers community consultation as well as training to the faculty, administrative staff, and students in a wide variety of areas from suicide prevention to conflict resolution. Through her collaboration with the Educational Opportunity Fund, she established the means by which ethnic minority students can informally interact with a psychologist, thus decreasing the stigma associated with seeking mental health services and increasing the likelihood that students at risk would seek psychological services in the future. Dr. Adkins-Hutchison also works in a private group psychotherapy practice in Freehold, New Jersey, providing adolescents, young adults, and adults with individual, couples, and family counseling for a wide variety of emotional and behavioral concerns. Doctor, welcome. We are delighted to have you join our webinar family, and now without further introduction, I'm going to turn tonight's presentation over to you.
Thank you very much, Marty and Kelly, for inviting me here this evening to speak to you about a topic that's significant for many reasons and of particular significance to me. I appreciate the opportunity that I now have to talk about a population that I spent a great deal of time working with throughout my career. I've worked for the past 16 years on 2 of the most diverse campuses in New Jersey and across the country, and it's afforded me the chance to interact with large numbers of students of color and to become immersed in understanding their particular issues and needs.
Dr.
So I'm pleased to have
Hutchison?
the chance. Yes.
I apologize. We're not seeing your slides yet.
Okay.
Did you say show my screen?
There we go.
Okay. Just put it into play mode.
All right.
Thank you.
Thank you very much. So, as I was saying, I'm pleased to have the chance to share some of what I've learned over all of that time with you tonight. The hope is that by gaining some insight into the unique perspective and experiences of this population with respect to mental health issues and help seeking, that the audience will leave with an increased awareness of the unique needs of this population. Ideally, they'll feel better able to offer understanding and guidance when called for to the African American students, clients, friends, or whoever it is that they're interacting with, for whom mental health services seem indicated as a means of support. Let's start by identifying exactly who we're talking about when we say African American. This is the group of individuals who are born in the United States who thereby are American of African descent, particularly black African descent. You may be aware of others in the population who appear to be African American and who you might think identify themselves as black, but given the opportunity to identify themselves, they do so based on their culture or their country of origin. So to say I'm Haitian American or I'm Jamaican or some such thing. It's important to consider these groups who are a part of the growing populations in the United States who will have similar experiences here because of being ethnic and racial minorities and appearing to be African American. One group would be individuals who are identified as Afro-Caribbean. They are hailing from the Caribbean islands. Those who were born in Haiti, Jamaica, Guyana, and Trinidad comprise the largest numbers of immigrants who've most contributed to black population growth in the United States from these areas. In fact, between the years of 1980 and the year 2000, the number of immigrants from these countries tripled. The other large group hails from Ghana, Nigeria, Ethiopia, and Egypt. During the same period of time, 1980 to 2000, the numbers of black African immigrants from the African continent, particularly the sub-Saharan countries, increased by 6 times. There are challenges that all of these groups face in this country, such as racism and discrimination. However, there are distinct differences between the groups. For example, blacks born outside of the United States don't share the recent history in the United States that African Americans do. And likewise, African Americans have not necessarily encountered the unique challenges that immigrants face, such as speaking another language in a foreign country. Each culture comes with its own unique experiences, beliefs, and values with respect to mental health and help seeking that is worthy of full discussion. And as such, I could spend about an hour, if not more, talking about each, but this would take a great deal more time than we have here this evening to outline each group and the issues regarding mental health that are specific to each of those populations. So for the purpose of tonight's presentation, the focus will be on the African American population. As I go throughout the presentation, more than likely I will fully say African American for most of the time, but if I use it interchangeably with black, from time to time that will be based on the research that was done and the term that was used and the group that was studied. But I may use it interchangeably in obvious ways because I want it to be assumed that I'm talking about the African American population and not all of the black population that I just described. So let's continue and start to consider why this topic is so significant. Some statistics regarding this ethnic group reveal that the needs for African Americans to access and receive quality mental health care are tremendous. The first fact in front of you is a tragic reflection of the impact of depression unchecked in the African American community. It says that suicide is the 3rd leading cause of death among African American males ages 15 to 24, behind homicides and accidents. When males in general choose to kill themselves, they typically choose more lethal means to do so. Because of the stigma related to identifying oneself as depressed for an African American individual and for men in general, and because it's common for African Americans not to be viewed as depressed by others, and we'll talk about that later, there are likely many suicides that mask themselves as accidents and so are misinterpreted. The number of suicides in the African American community reflected in this statistic may actually be higher because of that. The next fact is similarly tragic in terms of the spike observed for this age group. The suicide rate among African American children ages 10 to 14 increased 233% from 1980 to 1995. This demonstrates the absolute need for support and assistance in ways that either aren't being accessed, aren't available, or aren't perceived to be available to this segment of the population. It also points to the need for there to be a discussion, and many discussions, about recognizing a child in crisis and in need of mental health intervention. For those who do make it into treatment, compared to the general population, African Americans are more likely to stop treatment early and less likely to receive follow-up care. This could be related to the quality of the support that's offered and available to these individuals. It begs the question, though, is this a phenomenon attributable to the individual or to the treatment and what's offered, or both? Why is this important? Despite similar rates of mental illness across ethnic groups, only 27% of African Americans receive treatment, compared with 44% whites and 28% Latinos. This means that only 1 of 3 African Americans who actually needs mental health care receives it. 60%, that translates into 60% of African Americans who need mental health care do not receive it. It shows us that stigma against seeking mental health support in African American communities is alive and well. It's not the only factor, but it accounts for a large portion. And it shows us the level to which African American communities are underserved. What are the circumstances that prevent or deter African Americans from obtaining fitting support? The next statistics taken together offer some insight. The treatment that African American clients receive tends to be more intensive, meaning they typically are seen more so in inpatient settings and represented disproportionately in residential treatment facilities, and there's an underrepresentation of African American clients engaging in outpatient psychotherapy. Those statistics are very much related. The fact is that rates of mental illness are consistent across ethnicities. If there are increasing numbers of African American individuals who are experiencing symptoms of distress, but fewer are receiving services, there must be a disconnect along the way for the individual in need of these services. That is, if somebody is saying to themselves, if I need the services, why can I not or am I not reaching out in order to prevent greater distress? Do I know where to go? What will happen when I get there? Do I even believe that there's a reason for me to be thinking about going? Let's take a look. On the screen, you'll see likely a lot of very familiar faces, and just thinking to yourself how many of these faces are recognizable. Each celebrity that you see has been confirmed to have dealt in the past or to be dealing with some sort of mental health diagnosis. As I was doing the research and looking for faces with respect to who you know, who's visible, who's out there, it didn't take me long to search and find their pictures when I was looking for faces of mental illness. In contrast to this, it took me a bit longer to locate these celebrities. There were numerous examples of non-African American celebrities, but these were the consistent faces that I saw when I searched for recognizable African Americans with mental illness. I plugged in all kinds of words, all kinds of topics, all kinds of ways of twisting around what it is that I was looking for. In fact, there's one listing of, I think it was 44 celebrities with mental illness, and only one among the 44 was African American, and that happened to be Halle Berry. And when I searched for African American celebrities with mental illness, these faces were the ones that appeared and reappeared over and over again, which would lead you to believe that there aren't too many more people who are visible in the African American community who claim to be dealing with mental illness. In fact, on that list of African American celebrities with mental illness, there were a number of white celebrities who were thrown into the list, which was very interesting. And I did check the backgrounds. I thought, okay, perhaps I imagine that that person is a white celebrity. They're actually African American or identify themselves as such. And I came up empty. So I don't know exactly how it is that those faces were included on those lists. What are the implications of this? Well, if I'm an African American individual in this country and I'm looking around me to get a sense of how alone I am in my personal struggle with mental illness, or I'm looking to see who else shares my pain, I'm going to have fewer examples of others who look like me and who share my experience than my average white counterpart. I won't see me in medication ads, so I might conclude that medication is not for me. I don't hear that anyone else who looks like me feels this badly and calls what I'm feeling mental illness, so I figure there must be some other explanation for this emotional pain. This could influence me to feel even more isolated and alone when I have no images available to me of people who come from where I come from and have seen what I've seen and who are going through what I'm going through. So while the incidence of mental illness is equivalent across ethnicities, the visibility of mental illness in the African American community is quite low. Why could this be? What factors account for this? Let's move on to talking about what contributes to the development of mental illness in order to understand why it might be difficult for African Americans to be seen. Before we determine where African Americans with mental illness end up, we have to look at where they begin in this journey. Therefore, we have to look at what factors contribute to the incidence and prevalence of mental illness in the community. The first few: high homicide rates, high rates of high school dropout, high unemployment rates, high rates of homelessness, and incarceration. Each of these factors has been determined to contribute to the increased likelihood of developing mental illness in all communities. But what runs through as common among these factors is that there are a disproportionate number of African Americans represented in each of these categories. Below that, living in an urban community increases the rates of all of the other factors exponentially. Additionally, African Americans tend to be poorer in health than the larger society because they lack access to or do not seek adequate preventive services. It's well known that there are direct links between physical and mental well-being and health. So if you're not accessing services for your physical health and it's directly linked to mental health, those rates are going to be higher as well. It's also not uncommon for African Americans to present to physicians with physical complaints of illness without recognizing that their symptoms are an expression of a mental disorder. African Americans also tend to attempt connections with health providers later than other groups on the whole, and so the severity of their symptoms tends to exceed the severity of symptoms for their counterparts. And that directly relates to the conversation that I just had out loud with myself about, I'm feeling this way, where do I go, who do I see, and the time it takes me to ask those questions and keeps me from seeking services. One of the most significant factors that increases the likelihood of developing mental illness is persistent encounters with racism and discrimination. We know the damage that oppression can do, and it can cause an individual to think that he or she is crazy. I've talked with a number of students over the years who share this very common experience, and this theme is a common one in the women of color groups that I run, wherein students will describe encounters with overt or unintentional racism that leave them feeling hurt or frightened and alone in their pain. And without a place to share their stories and experiences and hear that their reactions are normal, they might otherwise have nowhere and no way to process their feelings, possibly leading many to experience above and beyond mild levels of depression or anxiety or things like that. So why does all of this not lead African Americans to seek support from the mental health community more readily? We have to look at the barriers to mental health care. With respect to the first fact, there are fewer than 4% of psychiatrists and 2% of psychologists who are African American. And African Americans are less likely than their white counterparts to find a therapist who looks like them because of that. It's been researched and demonstrated that perceived similarity between a client and a therapist, for example, is desired by many therapy seekers because of the perception that, well, this person looks like me and so they're going to understand me. That may or may not be true, but it does contribute to who it is that somebody desires to sit in front of them and reveal themselves to. And this is particularly true for African Americans. However, if I see few therapists like me, I'm less likely to pursue much needed treatment. Moreover, African Americans are more likely than many others to seek help from non-professionals, including family, social, and religious groups. If I'm used to relying on those with whom I'm most familiar to help me, it also deters me from drawing on unfamiliar sources of support. Another set of factors that often deters African Americans from accessing services are the values and beliefs that many share about mental illness and help seeking. The first refers to the belief within some significant portion of the African American community that your mind is more powerful than any mental illness. The belief for those with this perspective is that mind over matter and prayer are key to overcoming mental illness and its accompanying symptoms. You just have to put it in God's hands is the type of statement you will hear from the very strong faith-based individuals who are connected to the church, which has been a pivotal building block in the African American community historically. Another widespread belief in the community is that you don't share personal business outside of the home. I remember this personal memories growing up. My mother used to say, don't put your business in the street. If I said that out loud and my brother and sister were standing in the room, they would start laughing and we'd start talking about all kinds of stories about how we encountered that. It was clear to me that there was some potential consequence of this for myself and for my family that I had to prevent by never sharing problems or issues of any kind with anyone outside of my household, much less other kinds of things that were personal business, not just bad things, but anything that was personal business. And that sharing with no one meant no one, not doctors, not teachers, those kinds of things. There's definitely some anticipated shame or embarrassment that was also implied. So although my memories are that there wasn't really any business that I had access to not share, I knew that if there ever was, I was never to share it. The community has a legacy of holding on to secret lies and shame that date back to and originate from slavery. And this mistreatment has resulted in generations learning to mask and hide emotional pain so as to appear invisible and not vulnerable. So it has its origins historically in a very protective kind of place. Sometimes more currently, though, it's misapplied and can cause more consequence than it's intended. The third barrier to African Americans obtaining mental health support is due to seeing the need for a therapist and help as a sign of weakness or a lack of faith, as opposed to a reflection of strength. I just talked to a client the other night for who this core belief is that if she asks for help, it means that she's weak. And it's said with a very straight face and a lot of determination that I don't even know why I'm sitting here in view of you seeking help saying this, but I am. It's very much a conflict. There's also a powerful standard that African American men and women have been taught that they are to be, quote, strong black men and strong black women, meaning that they are to be present and capable for everyone in their family, neglecting their own needs. They're conditioned by this belief to appear as though they are not hurting. It's not unique to African American populations. There are many cultures that I've heard express some very similar things, but it's important to know that this applies to African American community as well. Similarly, therapy is believed to be for those people with inherent character flaws, and just in saying that those people with that tone is implied that there's something wrong. Therapy is often believed to be by white people for white people. In fact, mental issues are interpreted by many African Americans as reflective of a problem within an individual, not a health problem, not an illness. It's considered to be a personal weakness. The thread that runs through each of these beliefs is that of an attempt to maintain control and to not be overcome by something that you can't defy if you put your mind to it. In a society where the majority group has consistently asserted its dominance with respect to this population, it makes sense that African Americans have formed a set of values that encourage strength and self-reliance. Unfortunately, this strength is often no match for mental illness. As a result of these beliefs, many African Americans tend to shy away from everything and anything mental health. As I mentioned earlier, these factors are a result of this tendency to not access mental health care. African Americans are more likely to become depressed because of some of the factors I talked about before. African Americans are more likely to be hospitalized and received involuntary treatment. African Americans are more likely to be treated in an emergency room. And they're also less likely to stay in treatment and to be offered outpatient psychotherapy or newer treatments. As I mentioned earlier, these factors are a result of this tendency to not access mental health care. They can be understood as societal barriers to mental health care for African Americans, and the beliefs that lead African Americans to access care less results in the way is stated here. These represent a biased and often inaccurate depiction of all of who we are and what we need. If this is the way in which society perceives us and our needs and continues to interact with us in this way, it kind of perpetuates a feedback loop that discourages our utilization of services. That is, to put more plainly, if I feel depressed but believe that I should pray about it and not get treatment, my symptoms more than likely will worsen. They may not, but sometimes they will. Instead of seeking weekly outpatient therapy, I wait until I can't function, which leads me to feeling suicidal perhaps and in need of hospitalization, and you kind of see how one thing leads to another in terms of severity. If providers are not seeing me in their offices week to week, but are seeing me in the ER and needing hospitalization, it unfortunately reinforces the perception that African Americans more typically need higher levels of care. If my sense as a family member of this individual is, well, if I go complain about my symptoms, they're going to put me away too, then the cycle of avoidance continues, and we see how these societal barriers can impact the pursuit of mental health care for African Americans. Before I go forward, I have to qualify my prior statements about values and belief systems by cautioning that not all African Americans subscribe to the same set of beliefs. What it is that an African American believes about themselves, about who they are, and how they believe the world perceives them depends upon where an individual is on the spectrum of his or her racial identity development. And this model originally was developed primarily for African Americans to help with understanding their experience in the United States. The main premise is that an individual progresses from a state of unawareness of race, meaning not aware that race exists in a sense, who I am, who the other is, through an embracing of black culture exclusively, and on towards an embracing of and commitment to many cultures. So the more an individual has been able to integrate and accept both sets of cultural values into his or her way of thinking, the more able he or she is to value aspects of the dominant culture alongside the value of one's own culture. This suggests that the more an African American individual has acquired an integrative awareness of his or her racial self, the more likely the individual is to see the value of therapy for him or herself, as therapy is a value of the dominant culture within which he or she lives. So there are some African Americans who don't share the feelings of stigma about mental health services in ways that others do. You can't assume that within the African American community there's one way of thinking or believing about mental health or help seeking, but you must understand the values that are very powerful for some that are at play and prevent them from accessing services. Let's now take a look at the additional factors that contribute to the stigma regarding mental health services in the community. Some of the factors that contribute to the concern that African Americans have about seeking treatment for psychological concerns are related to economic issues. If I have fewer financial resources, then I won't be able to find anyone to help me. If I spend all my money on that, then I won't be taking care of my family, which is very much valued. Factors related to not having health insurance also come into play here. One statistic showed that 1/3 of working African American adults were uninsured during the prior year, and this would make their economic access to services limited. Another issue that contributes to the disbelief in the relevance of services to African Americans is the lack of proximity of services that many of them experience. There aren't any places nearby where I live, so they must not be for me. I mean, imagine this. If you are African American and living in, one of our major urban settings here in New Jersey, in Newark, and the closest individual provider to you, based on your health insurance, or perhaps not even having health insurance, is outside in the city of Bloomfield, which is demographically quite different from Newark, you start to wonder, can I get there? Will I feel comfortable when I go? Will I be well received? Will people, once I get there, understand why I'm there and what I need? That's of concern. The second set of factors that interacts with the hesitance that many African Americans have to pursue therapy is related to historical factors, some of which I've already talked about. Support from the church is major. That translates to, I've always counted on my pastor to help me with any problem. I'm not going to talk to a therapist. I don't need any stranger to help me figure this out. The second relates to the belief that we've survived a lot. I mean, big issues. There's slavery, there's racism, there's discrimination. And the belief that comes from that is I can just rely on my family and myself and my prayers to make me feel better. In fact, there's, been things that have been felt and communicated that we don't get depressed. I'll talk a little bit later about that statement and how that's seen and how that's still present today. The third, the fear that the system won't recognize cultural issues I've referred to. And the feeling is that, for example, if I go to see that old white man, which is the stereotypical representation of what it is that I expect to see when I enter into a therapy office, if I go to see that old white man, he's not going to understand what I'm talking about. He's going to think I'm crazy. What interacts with this fear is that the mental health was designed by whites for whites, as I mentioned before. I don't see anybody that looks like me. I don't know anybody who goes to counseling. So I don't think this is anybody going to understand where I'm coming from. Finally, there are historical thoughts about the delivery of mental health services that relate to the way in which psychology has implemented social policy in the past related to the African American community. There have been research done and psychological testing done, for example, and the results were used to justify segregated school systems historically. The African Americans have acquired a great wariness of systems in general for not having treated them respectfully. This stigma is kind of passed down through stories and through generation to generation in terms of people sharing their experiences. The final set of fear factors, as I call them, that tends to affect the avoidance of the mental health system is related to the psychological aspects of the African American experience. Within the community, our experience of trauma may be communicated and interpreted very differently than for a white counterpart. Sometimes that very traumatic things that African American children and adults experienced are normalized by the individual and by the treating provider, such as symptoms are misinterpreted or overlooked. This leads to unsuccessful encounters and discontinuing treatment. Secondly, African Americans have practiced ways of interacting with the larger society via wearing a mask so as to not expose too much and to appear vulnerable in a society that isn't always kind to ethnic minorities. This can be brought into the encounter with a mental health professional and prevent the accurate assessment of symptoms and rendering a fitting diagnosis, because if not enough information is being offered to me in order to know exactly what's going on, I'm probably not going to know exactly how to accurately diagnose somebody that I'm sitting in front of. The way in which African American clients express symptoms can be also very different than that of a white client based on the values we talked about a little bit earlier. One study showed that 15% of African American patients and 9% of white patients presented to their physician with physical complaints that were actually diagnosable as psychological symptoms. If no one understands that, sometimes you have to look beyond the physical symptoms. There's going to be a lot that will be missed. Also, a lack of familiarity with the treatment process and uncertainty regarding expectations can steer many African American individuals away from seeking services altogether. If I have no friends, like I said, I've had no friends to go to therapy, I didn't learn about it in school, I don't see media examples, I'm not touching it. The next aspect that can affect the pursuit of mental health services relates to the cultural mistrust that develops for African Americans with regard to non-African American others. In this case, treatment providers. It's the mistrust that has grown from actual negative encounters with members of the other group, and I can talk more about this later. Cultural misunderstanding regarding diagnosis is significant, as seen in one study that controlled for all kinds of variables and found that African Americans received a diagnosis of psychosis, which is pretty severe mental illness, twice as much or 2 times more than their white counterparts. And this is an example of the way in which a lack of cultural understanding of the way in which symptoms are expressed can lead to clinical misjudgment. The next set of factors speaks to this more directly. Oftentimes, concerns develop for African Americans based on the way in which they are treated by the mental health system when they do access services. There are many examples of the way in which a lack of cultural competence can interfere with the accurate diagnosis and treatment of the African American client. The first one, micro-insults, another way of terming that is microaggression, describes the social exchanges in which a member of the dominant culture says or does something, often accidentally and without intent and malice, that belittles and alienates a member of a marginalized group. And an example of this is oftentimes African American men in particular will talk about their experiences of walking down the street, whether alone or in a group, and noticing other people, particularly women, and very often non-African Americans, crossing the street, clutching the purse, things like that. Nothing is said and no words are exchanged, but there's a communication of fear, and that's considered a microaggression. Again, I can talk a little bit more about that later. And so when sitting with a therapist, if an African American male, for example, is telling this story, depending on how believable it sounds, it may sometimes be misconstrued as quite delusional, with somebody lacking the cultural competence to know this actually really does happen. This is a real experience for African Americans. It can be misperceived as something that's imagined. The second, emotional reticence, can be misunderstood as paranoia or severe mental illness. As I talked about before, the caution about talking with strangers and not disclosing much in sessions, especially to white therapists, which has been researched, can again be misinterpreted as not disclosing much, being very paranoid, and not understanding it as a healthy paranoia. I will also talk about that later, healthy cultural paranoia, and so can be misunderstood as much more severe mental illness. Dissociative experiences, for example, as seen in post-traumatic stress reactions or reactions to extreme stress, living in very violent and chaotic environments, etc. Sometimes people who have those experiences tend to dissociate or wander off in their mind in very simple terms. And instead of understanding that this comes from, again, real sets of experiences, it can sometimes be misinterpreted as psychotic, which, again, represents a much more severe form of mental illness. Unfamiliarity with slang can sometimes be interpreted without the knowledge as thought disorder, when there's not an understanding or familiarity that the way in which African Americans may sometimes speak sounds convoluted or confusing or just really not able to be understood. What it can be chalked up to is, well, their thinking must not be clear, this is reflective of something much more serious, and a misdiagnosis occurs. Sometimes, if we appear irritable when we're manic, instead of expressing that we feel euphoric, and that symptom is seen through a lens of cultural misjudgment, it can lead to misdiagnosis as just an angry black man. This has been studied by Arthur Whaley, who looked at how African American prison inmates were diagnosed much more frequently than their white and Latino counterparts as paranoid schizophrenic, instead of as being culturally mistrustful. It's possible that these factors account for the African American males having been sent to prison versus treatment facilities for their crime, as many non-black counterparts were. Also, if an African American person presents with no energy and feeling fatigued as one of the simple symptoms, and the focus is on that, again, as presenting to a physician, it may be overlooked as just a physical problem, as opposed to one of the major symptoms of depression, for example, and it's written off as physical and not reflective of mental illness. What results from this are the factors and the things that we see much more clearly that prevent African Americans from pursuing services. There are very often a shame, concerns about rejection, concerns about disconnection from their community for going outside the house, so to speak, Feeling marginalized and further marginalized by doing something that's unusual. Again, referring back to the angry black man or woman, that's how it is that I'm going to be received. That somehow they're going to find out, my boss is going to find out, it's going to go on my permanent record. We hear that all the time at university. If I come here, it's going to go on my permanent record. I don't know where they keep those and where that exists, but everybody's sure that this stuff is going to end up on it. And somehow will result in employers, current employers and future employers finding out and me not being able to pursue my career or get a job. Additionally, not being believed in ways that we talked about before, being perceived as weak, hurting the family, which translates as the outward admission of the family's failure to handle problems internally. Being perceived as crazy, which again is not an uncommon thing for many people, a fear that they have. But in one study, for example, for blacks who were already mental health consumers, over 1/3 of them felt that mild depression or anxiety would be perceived as crazy in their social circles, and that's within their social circles. And the final ones, as we talked about before, mistreatment by mental health systems and the fear that they're going to lock me up, they're going to pull the white coat out of the closet, wrap it up, and ship me off. In response to all of this, what can we do? Public education campaigns are designed to educate the masses and to increase the awareness of stigma towards mental illness. Ultimately, the goal is to decrease the stigma and to encourage help seeking in these populations. Here are examples of campaigns aimed at reaching the African American population, but looking to raise everyone's awareness of mental illness in the African American community. The first represents the images from SAMHSA's public education campaign regarding mental health stigma in the African American community in particular, and it was launched in 2010. The goal was to increase awareness and spark dialogue about these issues. The image on the right, I don't know how many people recognize her, but that's Susan Taylor, who was very open about experiencing major depression, and she's an example. She's the editor-in-chief of Essence magazine. It's a nationwide publication for African American women, and she put herself out there as someone who others would perceive as famous and wealthy and having it all, and she was depressed. The impact of having a very well-known face attached to an issue of such significance is priceless. It enables people to identify with someone everyone knows and extricates the shame from the situation at hand, potentially. The second one that I located depicts students at UC Berkeley who gathered at their main pavilion on campus in order to launch a public awareness campaign regarding mental health issues and help seeking. The hashtag Behind the Stigma campaign was initiated by the Black Student Health Association following the September 2014 suicide of an African American male student who attended the university. The messages that the students displayed on whiteboards directly speak to the stigma regarding mental health and help seeking prevalent in the African American community. They stopped and said something has to be done. In this generation, with us, something has to be done. So statements including, I'm not afraid to ask for help, don't judge me, stand by me, and asking for help doesn't make me weak, were written on boards to communicate directly to young adults in a way that's familiar to them. You know, all the whiteboards hanging on the university doors, that's what it is that they used. The messages speak directly to the stigma I described earlier. These phrases were seen alongside statements like, they told me black people don't need therapy, and break the stigma, don't let the stigma break you. It's inspired me to speak with my director recently about the way in which we on our campus can begin such a campaign here on the East Coast in order to address similar issues that we're seeing in our counseling center. Other efforts involve conducting programs within African American communities. There are great benefits to connecting with systems within the community, like churches, fraternal organizations, and such, in order to offer programs and presentations about the issue. Again, it increases the community's awareness of the issues, provides a forum within which they can discuss the issues safely, and overall decreases the stigma associated with mental health. Similarly, by identifying resources that are available, affordable, and local, it increases the likelihood that African Americans will access these services. The idea is, if you build it, they will come. Providing services at low or no cost and making the points of entry into mental health systems more accessible increases the likelihood of individuals utilizing services. Offering more discussions and trainings such as this one is key. It demonstrates the significance of the issue as one that's worthy of discussion. In addition, we as mental health providers and providers in all of the helping professions, that would be educators, advocates, ministers, and what I consider to be the biggest helping professionals of all, parents, need to learn more about African American cultural expressions, values, style of speech, mannerisms, and we need to familiarize ourselves with popular things, music, literature, anything, kind of immersing ourselves in learning about the culture as a way of increasing our cultural competence. For many African Americans who fear that I as a provider know nothing about them, if I demonstrate some working knowledge of things that are unique about them, and even more importantly, if I express a willingness to know more about their lifestyle, their history, and their interests, their worldview, their viewpoint, that can make the difference in decreasing fear and mistrust of interacting with me. Knowledge increases awareness, which leads to better recognitions of signs and symptoms, which then leads to appropriate conversations and interventions. Finally, mental health providers need to offer culturally sensitive treatment, which involves an understanding that racism, sexism, classism, and other forms of discrimination are real issues for African American clients, and that the concerns that they express about these issues are not a sign that they are too sensitive or paranoid. We need to understand and acknowledge that while African American individuals and families share many things in common with the larger population, there are aspects of their experience as people of color that distinguish them from other individuals and families. African American students express to me very often that they do not want to be perceived as deviant simply because they're different from their majority peers. They want desperately for those unique aspects of their experience to be heard and validated. And by doing this, it opens the door for increased trust and commitment to the help that's being offered. Another way that we can address the stigma is by getting more comfortable talking about race and culture. Expressing a willingness to talk about an African American client's experience of their blackness for themselves in interaction with others and in society can make the process of getting help easier for them. We have to become aware of our own biases and expectations regarding African American clients in order to truly be objective about their report of their experiences, in order to ensure that we're making appropriate judgments and not misjudgments. I had a conversation, I saw a conversation that I was having recently with a parent. I took that opportunity to quote-unquote have a conversation. I was sitting with one of the moms. I have young kids, and they were at a tryout for one of the sports that they're playing. And all the kids were running up and down. It was basketball. So they were running up and down the court, and my friend, who's a mom of one of the girls that was on the court, who happens to be white, wanted to point out one of the girls to me. She happened to be a very tall, probably trying out for center, very tall African-American girl who was noticeably and distinguishably black. And she wanted to point her out and ask something about her or say something about what she just did. And I saw her struggling. She said, "Do you see the," and she said, "girl in the pink shorts." And I was looking, and the shorts were covered up by a very, very long shirt. And so I was looking at the black shorts with the pink stripe, and I couldn't figure it out. And she reached up, and the shorts were exposed, and I said, "Oh, do you mean the black girl?" And we talked about it a little bit, about how uncomfortable it was for her. If she was blonde, she would have said the blonde one. If she was just tall, she would have said the tall one. But because saying that black girl or that African-American girl was just so attached to concern and fear for her about how I would perceive that, being African-American myself, I was able to have a wonderful conversation with her about the issue. And she expressed relief and a better understanding of how saying the tall black girl, which is what she really wanted to say, was so intimidating and loaded with threat and fear that she just struggled to find a way to use skin color as a descriptor without feeling that she was doing something terribly wrong. In terms of the therapy process itself, one of the most important components of the sessions with African American clients should involve psychoeducation. This refers to the education offered to individuals with a mental health condition and their families to help empower them to deal with their condition in an optimal way. Providing the person seeking services with an understanding of the benefits of treatment for them increases their likelihood of commitment to the therapy process and directly addresses the tendency for them to prematurely terminate counseling. Also, efforts to involve as many family supports into the treatment with African Americans when appropriate, such as when they are supportive and trusted, may greatly increase the likelihood of a positive outcome and enhance commitment to the process. Therapy has historically looked to engage only the individual in his or her own healing experience. It's important to recognize that this may be very different for African American individuals for whom family might be key to their healing and recovery. These days especially, all families don't look like this one. We definitely should not assume that because they don't look like this, that something is wrong with the individual or his or her family if they only have one parent, or they're being raised by their grandparents, or have some other family structure that doesn't resemble this one. It's important to not see deviance here either, as doing so will create some of the mistrust and distance that we talked about before between the African American individual and the helper. Any way that will make the entire process from start to finish less intimidating for the African American client will improve the chances that he or she will initiate contact, engage in the process, and have a successful outcome. I just heard one of my mentors speak at a conference at Rutgers recently, about a week ago, less than a week ago, and she's done extensive work in the African American population with children, adolescents, and adults and their families. And she was talking about engaging a client, and typically and traditionally the ways in which we're trained to engage a client involve some brief kind of getting to know that person and then kind of going into our assessment or our interview. And she was talking about engaging a client and about how important it is to recognize when getting to know someone should precede an intake form. Many times knowing where a client, in this case an African American client, places his or her value will lead you to take a different approach than a more traditional one, and will give you more bang for your helping buck. The biggest encouragement that I have is increasing recognition, increasing awareness, increasing knowledge, and increasing experience. There are a number of resources that can help with understanding unique aspects of working with African American clients. NAMI, National Alliance on Mental Health, is the nation's largest nonprofit mental health education, advocacy, and support organization. And it's dedicated to research, study, provision of services, etc. for the community. SAMHSA, which is the Substance Abuse and Mental Health Services Administration, is also a very important organization. It was the one that I referred to in the public education campaign a few slides back. Again, research, advocacy, services, etc. National resource, very, very important. Call Me Crazy is a Lifetime movie that raises a new understanding of what happens when a loved one struggles with mental illness. I think the stars are Jennifer Lewis, Jennifer Hudson, Ernie Hudson, among others, and really gives you somewhat of an insider's view of what it is to have a mentally ill family member and the interactions, particularly in this family, around that. Two great books, one by Freddie Paniagua and the other by Nancy Boyd Franklin, on working with African American clients in therapy, assessing and treating culturally diverse clients, and Black families in therapy. We'll find much of what it is that I talked about. I use them as resources very frequently. There are plenty of other resources out there, but I just wanted to kind of capture a few to lead you in the direction that you might want to in terms of finding out more on the topic. I hope that the information that was offered this evening was helpful, and that everybody's taking something away that's useful to them in some way. Maybe some new knowledge about understanding this population and the needs they have with respect to seeking help in their communities to deal with mental health issues. I wanted to share my practice information with you. I'm a part of a group, as Marty said, of culturally competent providers who offer services to individuals, couples, and families in the Monmouth County area, as well as to the surrounding counties in New Jersey. And if you'd like to dialogue about these issues or to gather further information regarding the presentation, as I said, I'm available for questions on the blog throughout the week, and don't hesitate to contact me there. I love to have discussions like this. It's kind of what I've built my practice and my career on, and I would look forward to your questions and your comments.
All right, thank you very much. You compressed a lot of great information into that presentation. And I have some questions that I'm going to kind of launch right into. I'm going to ask this question that was posted, and it may be more than you are in a position to go into today. Okay, so I'll leave that to you to figure that a little bit. But this individual, this mom writes about a 19-year-old son who refuses to medication and doesn't believe that he is ill. And yet he has seen therapists, and he's seen psychologists, and he's been diagnosed, and he's been in a psych ward for a while. And he actually hears voices. But he is adamant about his position. And how could you support this mother in terms of what she might be able to suggest or to move her son off this position that he has?
It's very difficult. Like you said, there is some distance I could go, but probably not too much, only because I don't know the specifics of the diagnosis. I have some sense just of what you're saying, but don't know the specifics of the diagnosis.
I understand that. Yeah.
Yeah, but one of the things that is clear is that just as with anybody, you cannot move anybody who doesn't want to move. And so one of the things that's very common to do with people who are what we call resistant to what it is that we know would be very helpful to them is to figure out what their motivation is, and to really, again, take his perspective on why he is so adamant about it, and therein might be able to find some clues as to how to pull him out of it in a sense, and more towards, it's just like with therapists. We can't understand. It's important for us to do therapy because it's really important to understand what it's like to sit in that therapy chair and really know what that person is going through. And because there's such a pull for him to get better and be better in ways that we know he can be better, it sometimes causes us to not really sit over in that chair with him. And so in general, figuring out what the motivation is, we do something called motivational interviewing. Well, what are the consequences to you? What do you want? Where do you want to be? Are you going to get there this way? Those kinds of things. And I hear there have been many therapists involved, and I imagine a lot of what it is that I'm talking about has been tried. But I think that understanding the perspective and him getting some sense that it is understood, it is accepted, because what choice do you have? You have no choice but to accept it. And motivating him to choose the other options that are available to him is probably one of the first best places to start.
Yeah. Okay, thank you. And I think that's a pretty right-on suggestions, because I think finding out what the reasons are for him not to want to proceed are really important.
Mm-hmm. Mm-hmm.
Okay. Have a question. Can you expand upon your earlier comments regarding microaggression and micro-insults?
Mm-hmm. It's, as I said before, it kind of consists of the insults and dismissals that non-Black Americans, and it's hard to use the word, but inflict on Black people. And Daryl Wing-Sue is the kind of the author of this, and really talks a lot about it in all of his works. It's the brief everyday exchanges that send the denigrating messages to certain individuals because of their group membership. And it's different from overt racism that we kind of recognize in historically in the form of skinheads or Ku Klux Klan or something that's much more overt. Generally just happens below the level of awareness of very well-intentioned members of the dominant culture, and it causes conflict with the person who's receiving it, because it's kind of, they say, did that happen? I remember experience when I was younger. I don't know, my profile is up on the website. I am a very light-skinned African American with blue eyes, and so the first person I think of, other than my sister who has blonde hair and blue eyes, and we identify ourselves as African American. I remember being a very young child, and I was in the place of not being aware of race very early in elementary school, and I remember being asked, "What are you?" And my identity from the inside out was I was Black. I didn't know that I was anything different from Black. And the question that came back to me, or the statement that came back to me, "No, really, what are you? No, you're not Black." You're just kind of confused me. I remember going home and saying, why don't they see me? Why don't they accept what it is that I'm saying? And it's the kind of action that can have a very devastating effect if somebody isn't able to kind of feel it. If somebody doesn't say, yes, that's been my experience too. And it has been adapted more recently to encompass the casual degradation of any socially marginalized groups, such as poor people, disabled people, sexual minorities, those kinds of things. There are different levels. He talks about it appearing in three forms. There are micro-assaults, which is an explicit racial derogation, kind of like verbal, nonverbal, name-calling, avoidant behavior, kind of like clutching the purse that I talked about before. Purposeful discriminatory actions. I apologize, not like the purse grabbing, but more purposeful discriminatory actions. And then there's the micro-insult, which is what I talked about. Communications that convey rudeness or insensitivity, kind of like, are you sure you have, yes, go ahead.
No, I'm sorry. Go right ahead. I didn't mean to interrupt you.
Okay. It's kind of like, there's a story of an African-American young man in medical school who was standing on the lunch line with his peers dressed in the white coat with the stethoscope hanging around the neck. And a woman walks up and says, just directly and clearly to him, "I'm sorry, do you work here?" Those kinds of things, assumptions that are made based on stereotypical biases that one holds that they're not aware of. And then there's the micro-invalidation, which are communications that exclude, negate, or nullify the thoughts, feelings, or experience of a person of color. And the guidance here is really for everybody to be aware, to accept that it exists and that it happens, that everybody commits them. It's not intentional. They typically are not intentional. And if someone kind of says, you're kind of accused of committing one, that you should really remain non-defensive and quickly apologize and try to understand again. It's all about understanding and recognition and acceptance of somebody else's experience.
Do you think that this whole technology boom that we're in right now exacerbates this microaggression and insults? I mean, isn't that something that just seems to be showing its face all over the place anyway?
Yeah. There's a lot of technological courage out there. People have the ability to communicate without having to really name or take ownership for what it is that they're saying and their emotions. And so it does provide another opportunity. Nobody in New Jersey would have ever been able to insult anybody in Ohio in years prior, but you can very quickly and easily do that, somebody in New Jersey to California. And so it increases the incidence and prevalence of such things, but also removes the need for anybody to really take responsibility, to remain anonymous. I mean, how often in years past would you be able to remain anonymous with the types of insults or things like that that were perpetrated? So absolutely.
What would you recommend to educators to do more with respect to working with African American children who they encounter in their classroom?
I think the biggest thing in terms of the things that I've read and the research that I've seen, again, the conference that I went to, there was a wonderful speaker and he was talking about the achievement gap and the standards and the expectations that are set and how those are fueled by our biases and our beliefs. And I'm going to kind of beat a dead horse and say it's about awareness, it's about recognition, it's realizing what it is that somebody's experience is, so that when you see a child, for example, who is acting out, that child is not seen as a behavioral problem, but perhaps having problems with his behavior because of something else. To recognize that, to not imprint your biases, become aware of them and not imprint them on the situation. Recognize that you bring something to the interaction and really be able to look at the child as objectively as you would any other. But also recognizing the factors that when you want to say something, when you want to do something, the people that it might be really important to connect with in order to do so. So whether those are whoever within a school system, outside of a school system, whoever the other trusted individuals are for that child or for that young person, to engage them in whatever intervention or communication or interaction that you might want to have, to mediate that, to become a trusted individual, to really, again, as with the 19-year-old, to really explore why it is that that child is doing what it is that you see them doing, to understand that, to not assume that if you see a furrowed brow and a crossing of the arms and a stomp of the foot, that's anger. That could be very protective, because if I'm a young black man, I can't sit here and cry. That's going to be really bad for me. To be Royce White, African-American male who, is going through a lawsuit right now at the Houston Rockets. He's got a, triple problem. He's African-American, he's male, and he's an athlete. He's not supposed to have mental illness. So, quote unquote. And so looking at that, understanding the factors that are creating what it is that you see, and realizing that everything you see isn't necessarily what it is. To look beyond that, I think, is really important.
Okay. I have a question from a mom of a teenage girl, and the mom has convinced her daughter to see someone about anxiety. But the aunt and the grandmother, who are very big role models in the family, kind of are interfering and say she doesn't need to do that. So do you have any suggestions on how to deal with that situation?
again, I think the answer is very interesting that the answer, the first thing that comes to me is the same, is to, particularly, not uniquely, but particularly in the African American community, seniors and elders and people with the wisdom are very important to engage in the process, to invite them in to understand their perspective and why it is that they think it's important that she not be here, to speak with them first and seek them out first, and to really engage them and to understand and to kind of meet what it is, again, that we see the need might be, and what it is that the child wants or the child is agreeable to, and how it is that that can work for them, what they see as the solutions to the problem, what do they think that she needs to do. Those kinds of things can help to mediate that process and encourage them to engage, or permit her to engage in that process. And the mother, like you said, is also a young person with respect to that grandmother. You know, that's her daughter. It may or may not be her daughter, but that's her daughter. And so there's a certain amount of respect that it sounds like she has for this grandmother's resistance and hesitance to have her engage in this possibly very unfamiliar, very problematic kind of process that she doesn't know anything about. And so as opposed to approaching it to engage, to educate her, it's kind of flipping it and having her educate you. She knows that young woman better. She knows her longer. And she has very important perspectives that might be very, very helpful to you and the work that she might permit you to do at that point. But if grandma says no, if Nana and Mama or grandma says no, and mom agrees with that, unfortunately there's very little that you're going to be able to do. So it's important to go there first, to speak with her first.
Okay. All right, kind of run interference before
Yes.
you get to that. Okay. Would you talk, what did you mean by cultural competency? Could you talk about that a little bit?
Sure. The concept of cultural competency has a positive effect on patient care delivery by it enables providers to deliver services that are respectful of and responsive to the health beliefs, practices, and cultural and linguistic needs of diverse patients. It really is, again, increasing your awareness, your knowledge, your experience of cultures. We can't know everything that there is to know about every culture, but it's critical to reduce the health disparities and improve access to health care, and health care that's respectable and responsive to the needs of the diverse patients. You know, behaviors, language, customs, perspectives can all influence health communication. So it's critical for achieving accuracy in research, in interacting with people. Cultural competence is just increasing your ability to interact with diverse cultures by learning more about them, simply put.
Did I lose you?
No.
Oh, okay. You seem to fade right out. I'm sorry.
Oh, I'm sorry.
So I'm sorry. Are you finished? I didn't want to interrupt you.
Yes. Yeah,
Okay.
it really is. It's a big way of saying, as I said, it's a big way of saying becoming more adept by acquiring knowledge, experiences, training, those kinds of things in diverse populations. Understanding, like I said, those behaviors, the language, customs, beliefs, just really becoming more knowledgeable about those things.
Okay. So in that question with regard to cultural competency, so then what is cultural paranoia then? Just the opposite of that?
No, not the opposite of that. It's not so much related. The paranoia that I talked about before, in particular with schizophrenic patients, when somebody has psychosis, sometimes one of the symptoms is paranoid delusions. And when an African American client, for example, is more cautious or more withholding in terms of what they're offering, that can be perceived as clinical paranoia. It's healthy cultural paranoia, or there's another term. The term was coined by Greer and Cobbs to describe the type of response to stereotyping in African American men originally. There's a history of racial stereotypes and associated negative consequences that have contributed to the development of healthy cultural paranoia. Cultural mistrust, that's the other way of talking about it, on the part of African American males.
Okay.
And it's, you know, now with the development of that recognizing that they're reacting to real negative experiences, and so they've developed a healthy caution, so to speak, a mistrust of somebody who potentially will mistreat me. Does not mean that I'm clinically paranoid. Doesn't mean that I believe that you are out to get me. I'm just aware that, you know, people may have been out to get me before in real ways, and so I'm more cautious. But it's not necessarily a clinical sign or symptom of psychosis, for example.
Okay, all right, I understand now. I think we have time for one more question, and it has to do with the celebrities that you featured on your slides. And then you said something else about media examples. So it seems that there is a real benefit to and not just in the African American community, but it would seem to me across the board, to have those role models of well-known people that come forward. And it would seem to me that that's a very positive thing to do, and a good program to enlist if you could get that going in a positive way.
Absolutely.
Or am I thinking wrong about that?
No, no, absolutely not. Disconnected from celebrities, let's say, myself. I've been very disconnected. So when I went to search, I kind of thought, okay, people are much more out in terms of all the kinds of experiences that used to be so negative and secretive and hush-hush. And it was very interesting to find, well, no, not necessarily. I think there are some of these things that the beliefs, the values that run very, very deeply and still prevent those people who do have power from utilizing that power in the form of identifying themselves as having mental illness. And it's still, to some degrees, not as acceptable. When you have fewer African-American movie stars and fewer African-American leading, I think there's some of the concerns about losing your job. Am I going to get jobs? Are people going to respond to me? This is very, very precious to me. There's not a lot of us. I think some of those things that run through communities at all levels run through that community as well. But you can't, I think it's priceless. You cannot, to have a spokesperson who is very well known and to go, oh, that person is dealing with that? Well, it's not so bad. I can kind of acknowledge that for myself as well. I think it's very powerful. I think what the students at UC Berkeley are doing is very, very powerful. Now, that's somebody my age that I see. That's just for old people. That mental illness thing, that's just for old people. But I see people my age who are brave enough to stand up and say, yes, I'm struggling. Yes, I'm dealing with this, and it's okay. It doesn't mean that I'm crazy. It doesn't mean that I'm bad. It doesn't mean that I'm weak. I think it's very, very powerful.
All right, well, I think that's a good positive note to end on, being powerful. So I'm going to wrap it up here. Doctor, thank you very much. That was a great, informative presentation. I'm going to turn this over to Kelly now, and she'll do a bit of a wrap-up.
Thank you so much.
Oh, you're most welcome.
Thank you all for joining us on our webinar on mental health stigma and finding services in the African American community. There is an exit survey. We would like everyone who attended to fill out this exit survey. The webinar blog is now open and available for the next 7 days on the NJCTS website for any additional questions that were not covered in tonight's presentation. That website is www.njcts.org. Also, an archived recording of tonight's webinar will be posted to our website. Our next presentation, Getting Kids Motivated for School, Strategies to Foster Your Child or Teen's Motivation to Achieve in School, will be presented by Dr. Graham Hartke. This is scheduled for November 12th, 2014. This ends tonight's webinar. Thank you, Dr. Hutchison, for your presentation, and thank you, everyone, for attending. Good night.